Welcome back to Neurology 101 on the ProPA podcast. I'm Dr. G, and today we're taking a closer look at herpes zoster, commonly known as shingles, and its serious neurologic complication, varicella zoster virus encephalitis. You may think of shingles as a rash, but when VZV affects the central nervous system, it becomes a whole new level of dangerous. Let's dive in. Did you know that herpes zoster or shingles isn't just a painful rash? It can lead to stroke-like symptoms in older adults due to VZV-induced vasculitis of cerebral arteries. And while we think of shingles as a skin issue, VZV can also cause encephalitis, meningitis, or even cranial nerve palsies, especially if the rash appears on the face. Let's dive a little deeper and talk about the kinderpatho. What is VZV encephalitis? Varicella zoster virus is the same virus that causes chickenpox. After the initial infection, it lies dormant in the central nerve or dorsal root ganglia and can reactivate later in life as shingles. When reactivation spreads beyond the sensory nerves, it can involve the central nervous system, leading to meningitis, vasculitis, myelitis, or cereballitis. CNS involvement occurs more often in immunocompromised and older adults, but it can happen in otherwise healthy patients as well. So, how do these patients typically present? Well, herpes zoster or shingles presents with a painful unilateral dermatomal rash that's vesicular. It may be preceded by a burning pain or paresthesias, and it's most common in the thoracic or cranial dermatomes. If it affects the eye, cranial nerve V1, that's called herpes zoster ophthalmicus, and we have to refer these patients urgently to ophthalmology. Ramsay-Hunt syndrome is when cranial nerve 7 is involved with ear vesicles and facial palsy. VZV encephalitis includes a headache, fever, confusion or altered mental status, plus or minus seizures, ataxia, or even focal neurologic deficits. A rash may or may not be present in this case. All right, so how do we diagnose this? Well, a lumbar puncture is going to show us the CSF with lymphocytic pleocytosis, a normal glucose, and an elevated protein. The VZV PCR of CSF is diagnostic. An MRI of the brain may show white matter changes or vascular involvement if vasculitis is present. And skin lesion PCR or Sank smears, if vesicles are present, can also assist in the diagnosis. So, how do we treat this? For shingles without CNS involvement, we can give oral acyclovir, valacyclovir, or famciclovir. Ideally, we want to start this medication within the first 72 hours of rash onset. Pain control can also be given, including gabapentin, lidocaine patches, and NSAIDs. For VZV encephalitis, we want to give IV acyclovir. This is 10 to 15 milligrams per kilogram Q8 hours for 10 to 14 days. We also want to consider corticosteroids if vasculitis is suspected. We also need to include supportive care and seizure management if needed. All right, now let's look at the book med versus the street med. Book med is going to give us a vesicular rash with a dermatomal pattern, and this is going to be classic for shingles. A confusion plus a rash is going to be the VZV encephalitis. Street med, however, will give us maybe a 70-year-old with diabetes who complains with burning shoulder pain. 2 days later, a rash pops up in the T4 dermatomal line. You catch shingles early and avoid post-herpetic neuralgia, but another patient has no rash, just confusion and fever. LP shows VZV PCR is positive. You just caught an encephalitis that others might have missed. All right, some quick clinical pearls to wrap things up. Herpes zoster ophthalmicus needs an urgent referral to ophthalmology. Post-herpetic neuralgia can last for months. Prevention is key. VZV encephalitis can occur with or without a rash. High suspicion is needed. Early antiviral treatment reduces complications, and a zoster vaccine reduces the incidence and severity in adults greater than 50 years old. All right, now it's time to test our knowledge with some practice questions. Question 1. A 68-year-old presents with a vesicular rash in the left forehead and eyelid. What is the next best step? Is it A, oral acyclovir only, B, IV acyclovir and urgent neurology referral, C, oral antivirals and an urgent ophthalmology consult, or D, high-dose corticosteroids alone? I'll give you a few seconds. If you said C, oral antivirals and urgent ophthalmology consult, you are correct. Remember, herpes zoster ophthalmicus needs both treatment and an eye evaluation. Question 2. A patient with no skin findings presents with fever and confusion. CSF shows lymphocytic pleocytosis, and a VZV PCR is positive. What is the treatment of choice? Is it A, oral acyclovir, B, oral valacyclovir, C, IV acyclovir, D, oral famciclovir, or E, IV ceftriaxone and vancomycin? I'll give you a few seconds to think about it. If you said C, IV acyclovir, you are correct. Remember, CNS involvement from VZV requires IV acyclovir. All right, so some final thoughts. Herpes zoster is more than a skin condition. It's a neuroinvasive virus that can cause serious CNS disease. Early treatment makes all the difference, whether it's for the rash or full-blown encephalitis. Next up in our CNS infection series, we have HIV-associated neurocognitive disorders, or HAND for short, where viral suppression meets cognitive decline. Know someone reviewing dermatomes and CNS bugs? Send this episode their way. And remember, this is the ProPA podcast, where future pros in medicine are made. I'll catch you later.